Dr. Lee, thank you so much for joining us today, and I'm just going to give you the floor, sir.
Thank you, Norma. Thanks for that positive energy. I think that's exactly what we need. At this time, the winter's been bitter and cold, so I hope
Yeah.
everyone here can have a little bit of warm up during this session. I'll be presenting. I might use a little bit of, technical terms. If you feel like, oh, this is too difficult, I can't follow, feel free to raise your hand or stop, interrupt me, and I'll be happy to answer those questions. And after the presentation is completed, you will also have time to ask me questions. So let me go ahead and share my slides here. How does this look?
Perfect. Yes, sir. Go right
Excellent.
ahead.
So as Norma introduced me, I'm an assistant professor at Columbia University. I'm a neurologist, ALS doctor, and also ALS researcher. And as you know, ALS is not a one disease. Motor neuron disease is not a one disease. And my interest extends beyond ALS to all motor neuron diseases, including PLS. And today I'll be mostly talking about PLS natural history study. I'll talk about the outcomes used in PLS population and discuss what kind of outcomes do we need for a clinical trial. Um, these are my disclosures. I do receive research supports, and one of them is coming from the Spastic Paraplegia Foundation, so I really appreciate your generous support. So the crowd here doesn't really need a lot about the PLS. You already have a lot of information and knowledge about the disease. It's a rare neurodegenerative disease affecting upper motor neurons, and currently there's no disease-modifying treatment. And in fact, there really hasn't been a real clinical trial done in this PLS population. Because PLS is devastating and it affects your function in every aspect of your daily living, obviously there's an urgent and unmet need to develop treatment in PLS. However, there are a lot of challenges, and there's a reason why there hasn't been any PLS clinical trial. I'll say the major hurdle is the rarity of the population that's affected by PLS. ALS itself is not a common disease. We think about um, maybe around 5,000 people get affected in the United States. Now, PLS is only about 3 or 4% of ALS, meaning that very small number of patients get new diagnosis of PLS, which makes the trial difficult because we might not have a big population. Now, further to that problem, we did not have a very well-defined criteria for PLS. We did, but that criteria has been evolving over time. And then other key challenges include disease-specific outcome measures that was recently developed and biomarkers that's been largely absent. So I'd like to introduce some of the recent efforts that we made, including the PLS consensus diagnostic criteria, and then the development of specific outcome in PLS called PLS Functional Rating Scale. There had been big efforts by Dr. Mitsumoto and colleagues in establishing and collecting the data from PLS natural history study, which will be the main part of this presentation today. I'm going to show you what kind of lessons or knowledge we obtained from this cohort. And then I'll introduce toward the end of the presentation the extension of the PLS natural history study and what we are aiming with that additional project. So PLS, or primary lateral sclerosis, I think it's a very interesting entity. It's a motor neuron disease, but affecting only the upper motor neuron. And the first term, primary sclerosis of the lateral column, which coined the term PLS, was introduced by John Merton Charcot. And then the description by Wilhelm Heinrich Erb, as you can read it, it's really fitting with what we understand the PLS as of today. What he wrote at the time was PLS usually begins slowly and insidiously, with some sense of weight dragging and slight feebleness in one or the other leg without pain. The condition progresses just as slow as it commenced. The legs become stiffer and heavier, the gait progressively more labored, dragging, and distinctly spastic. Occasional muscular cramps and contraction of the legs may occur, but nothing else. Objective examination reveals the characteristic symptom triad, certain weakness, awkwardness of movement, and very slight, so that often, for a long time, nothing in the way of paresis, much less paralysis. No ataxia, but far more distinct and prominent are the spasm and rigidity of the muscles, and well-marked exaggeration of tendon reflexes, which involuntary clonus of the foot. So you might hear these words and resonate with what you are experiencing. Now, for those who might not have the good understanding of our neuroanatomy, I'd like to give you a little bit of an overview and what might be happening with upper or lower motor neuron degeneration. So on the right side, you are seeing corticospinal tract, where your upper motor neuron or the cortical motor neuron starts in your brain, the precentral gyrus. Those are the those are the cells that sends down a long axon. Those are the tracks, like a train track, or the wires, down toward your brain stem in the midbrain, going down the medulla, going down the spinal cord, and it crosses to the other side, somewhere in the lower brainstem, and becomes lateral corticospinal tract. And then that axon later synapse, so meeting the lower motor neuron cells. Those are the second station. Those are different cells living in the spinal cord, anterior horn of the spinal cord. And that lower motor neuron would send out a nerve towards your muscle and connect with your muscle. So I typically explain this to my patient that we have two sets of motor neurons, upper motor neuron in the brain, lower motor neuron in the spinal cord. And the upper motor neuron connects to the spinal cord through this long axon, and lower motor neuron connects to the muscle with the long axon. And with these two tracks intact, you'll be able to voluntarily move your muscles. However, with degeneration, either the upper or the lower motor neurons, you develop dysfunction in the muscle. Now, very interestingly, depending on where the problem occurs, you have different kinds of problem. For example, in the upper motor neuron degeneration, your muscle strength remains pretty strong. You don't develop a lot of muscle wasting. However, controlling those muscles get difficult. They get stiff, they get slow, and don't listen to you. Whereas if you develop lower motor neuron degeneration, your muscles get very weak. They disappear, called muscle wasting or atrophy. And then the reflexes go lower, the muscle tone goes lower, and muscle twitches and cramp. So in ALS, both these upper and lower motor neurons are degenerating, so you have this combination of different symptoms. Well, whereas in PLS, because the only upper motor neurons involved, typically people slowly develop muscle dysfunction, stiffness, and slowness, but the muscle power itself remains quite strong. Even when it's weaker, it doesn't usually go to complete paralysis. Now, I also give you a little bit of overview in motor neuron disease. It's a spectrum, it's heterogeneous, it's not one disease, and there are different ways to group them. One way to group them is depending on which side, upper or the lower motor neuron, which side is predominantly affected. And you can see in the upper motor neuron side, there are primary lateral sclerosis and hereditary spastic paraplegia. Those are the diseases that's prominently affecting the upper motor neurons. Whereas on the other end of the spectrum, only the lower motor neurons affected. For example, spinal muscular atrophy, that's SMA, or spinal bulbar muscular atrophy, that's Kennedy's disease, and then progressive muscular atrophy. Another way to group these diseases is by inherited versus sporadic. So inherited condition, you can imagine, has a genetic variant or genetic mutation that's causing the disease. For example, SMA is caused by mutation in the SMN gene. Hereditary spastic paraplegia has a lot of many of the genes that we identified causing this HSP condition. Now, in the middle, ALS can be either inherited and those carrying the genetic variants causing the disease, or sporadic. We don't have the genetic variant in the person, but still the patient-developed ALS. Also, ALS involves both upper and lower motor neurons, and it's the most common form of the disease. So if you look at the PLS is on the sporadic side. So typically we don't see genetic variants, although very few cases, there are people with C9 who develop PLS. And then PLS is also upper motor neuron only or very upper motor neuron predominant disease. So this kind of gives you where we are in terms of the motor neuron spectrum. So many people wonder about PLS and ALS. Is that two different diseases, or is that just on the same spectrum, but PLS being on the extreme in that spectrum? I think we still don't have one clear answer. And if you ask different ALS researchers or providers, they might have different answers for you. Now, one kind of universal hypothesis that includes both ALS and PLS is a TDP-43 hypothesis that we are at this time thinking that TDP-43 aggregation is misfolded protein and it gets aggregated inside your neurons in the brain and spinal cord is found in many of the neurodegenerative diseases, but obviously more profound in disease like ALS, frontotemporal dementia, and potentially be the reason why the motor neuron disease is dying. This has not been confirmed in 100%, but I think that's a leading dogma in the field. And TP43 is very interestingly has a prion-like spreading properties, meaning that if one cell accumulates a lot of this TP43 inclusion or aggregation, that can be propagated from cell to cell. So it kind of gives you an idea how the disease can start in one area and then spread to the whole body. Interestingly, TP43 inclusions or disaggregations are obviously observed in ALS patients' brain and spinal cord, but in many of the PLS cases that are reported, we are seeing the TP43 inclusions. Because the TP43 inclusions are found in the brain of the PLS patients, people were interested to look at TP43 in the spinal cord because the lower motor neurons are typically not very much affected in PLS. I think it's fascinating that in some cases, TP43 were found in the spinal motor neurons in patients with PLS who doesn't have obvious clinical manifestation of lower motor neuron degeneration. And this kind of gives me an idea that PLS might be in a spectrum of ALS with the TP43 proteinopathy, but somehow has some protective factors preventing the TP43 spreading to the lower motor neurons or the spinal motor neurons. And to further investigate this, we need a lot more people to help us with the autopsy program, donating their body to science. If you're interested, you can potentially contact me. We run a program at Columbia. Now, this might be a similarity between ALS and PLS, but obvious differences. ALS progress a lot faster, and PLS functional decline and overall progression is much slower. Another interesting observation we made in the PLS population is that weight loss that's quite prominent in ALS population. Sometimes people lose 20-30% of their weight. This is really not observed in most of the PLS population. So in the figure on the right side, there are a lot of dots, red dots and blue dots. What I'm showing you here is the monthly change of your BMI. So your BMI might be 25, might be 30. It gives you an idea how much of adiposity you have. Now BMI changes, usually it declines over time in ALS. And you can see that the red dots are all over the place, meaning that in some people, BMI decrease can be 1 point, 1 unit per month. That's huge loss of weight and BMI. The blue dots are mostly scattered around the 0. That means the BMI change is quite minimum. And along with that, the monthly ALSFRS, which is a marker of function, or your overall function, decline is, of course, the amplitude is a lot larger in ALS. You can see the red dots scattered from 0 to 6, some people losing 6 points of ALSFRS per month. In PLS, also the ALSFRS change it quite slow. People are usually around scattered around zero, meaning that they're not really losing a lot of ALSFRS score per month. So you can see how the magnitude of change in function and weight are a lot larger in ALS compared to PLS. It kind of translates into the survival too. So if you look at the survival graph on the bottom there, the red graph is again ALS and the blue is PLS. ALS patients start from month zero, start dying, and about 24 months, half of the patients already died, while PLS patients in blue, the death is quite rare and they were able to survive. More than 80% of them survived over 5 years. So these are the obvious differences between ALS and PLS. Some people think PLS is a distinct entity of the disease. Now, many times, it is not very easy to distinguish or make the diagnosis of PLS, and that's why the ALS and PLS experts got together and came up with the consensus diagnostic criteria, and this was established in 2020. Some of the key items for making PLS diagnosis, there's an age criteria. So this is PLS is a disease of adults. And the symptom needs to be progressive and showing signs, symptoms and signs of upper motor neuron dysfunction for at least 2 years. So you can see already that it's very difficult to make the diagnosis if the symptom duration is less than 2 years. That begs the question, now what are you going to do if your symptom has been there only for a year or less than 2 years? And then we need to see signs of upper motor neuron dysfunction at the time of examination in at least 2 of 3 regions. And those regions are cranial, your face and your bulbar, cervical, your arms and your hands, and then lumbosacral, your legs. So when the neurologist examine you, we want to see, or we need to see signs of upper motor neuron dysfunction in 2 out of 3 regions. And then we want to make sure that the person does not have obvious sensory symptoms, which is usually not part of PLS, doesn't have active lower motor neuron degeneration, because active lower motor neuron degeneration, either on the neuro exam or EMG, usually indicates that the lower motor neurons involved, and that meets the criteria for ALS. And then alternative diagnosis, such as hereditary spastic paraplegia, which can be tested with genetic testing, or, for example, Parkinson's disease that has different features like resting tremor, or multiple sclerosis, which comes with typically lesions on the MRI, the bright lesion in the brain or the spinal cord. The caveat from this consensus diagnostic criteria is they assigned how confident are you with the diagnosis. So as the duration of the disease is longer, we are more confident with the diagnosis. With probable PLS is defined with 2 to 4 years of symptoms. And then we can make definite PLS diagnosis if you had this upper motor neuron dysfunction for more than 4 years. So that means that in order for me to tell you, oh, you have definite PLS, it takes more than 4 years for you to have those symptoms. And that's when we finally can say, this is not ALS, but this is PLS. And obviously there's a lot of room to improve, because we don't want to make the PLS diagnosis after 4 years. We want to make the PLS diagnosis as soon as you start having problems or symptoms. So these kind of two recent advancement, the diagnostic criteria, and then I'm going to introduce a little bit about PLS-FRS later on, led Dr. Mitsumoto and his colleagues to found and collect data with PLS natural history study cohort. And the study was a prospective, meaning that we enrolled people prospectively going forward. This was a longitudinal study, meaning it's not just looking at people one time. It's looking at people at baseline, 3 months, 6 months, 12 months, 12, 24 months. So collecting all the outcomes at follow-ups. And then this was a multi-center study, 30 sites across the United States and Canada, so we can be more representative of the whole nation instead of just a regional center. After more than 5 years of study duration, we were able to enroll 76 individuals with PLS. And among those 76, 44 of them were definite PLS, meaning that they had symptom duration over 4 years. And then 26 of them were probable PLS, symptom duration from 2 to 4 years. Now, very interestingly, we also included early PLS. So early PLS was not even defined in that diagnostic criteria, but we wanted to include those early in the disease because even when we were not very confirmed or confident with the diagnosis, we wanted to see where they go in the future years. And only way to do that is by enrolling them in the cohort. So those who had less than 2 years of symptom duration, we weren't even able to give confirmed diagnosis, but we still included and followed them in this study. Importantly, we collected a very comprehensive set of outcome data in this cohort, namely PLS-FRS, ROADS, Pan Upper Motor Neuron Score, slow vital capacity, timed up and go test, finger and foot tapping test, and QOL, quality of life measures. And I'm going to go over those each outcome a little bit more in detail so you can understand what we are measuring with those outcomes. We asked the sites to perform EMG for our participants at baseline and 12 months, so we can ensure these are PLS patients and not ALS, and also make sure that whether they converted or changed to ALS at 12 months or not. We collected baseline and follow-up blood and urine samples, and we have analyzed baseline blood samples for plasma neurofilament light, which is a well-known marker of neuronal degeneration and has already been used in ALS clinical trials. And then I finally analyzed the data from baseline to 1 year follow-up presented, and I'm going to show you those data here today. So PLS-FRS, PLS Functional Rating Scale. You might have heard about ALS Functional Rating Scale or ALS-FRS. PLS-FRS was developed based on ALS-FRS, and we wanted to be more specific to PLS. We also wanted to be more sensitive so that we can reflect even the small changes that were not detected in ALS-FRS because the progression was slower in PLS than ALS. Now, ALS-FRS-R had 12 questions, so PLS-FRS also included the same 12 questions. With that same 12 questions, we added more detailed answers for the each question so that we can more sensitively reflect for the functional change. And I'm going to show you one example of that. There are 12 questions in 4 domains. So these 4 domains are your gross motor tasks, your movements, gross motor movements, your fine motor tasks, like with your hands, bulbar functions, your speech and swallowing functions, and respiratory functions. So each domain has 3 questions. PLS-FRS would range from 0 to 68, 68 being normal function. So if you don't have any issues with your function, you'll be 68. People typically go lower over time, and 0 indicates there's no score, no function at all. This PLS-FRS was tested in among PLS population, and we have shown that it's a very reliable scale in every domain, every direction. So one of the question I can show you what it looks like. Number 1 question on speech. So how are you doing with your speech? And the black answers are the options with ALS-FRS. So normal speech process, detectable speech disturbance, intelligible with repeating, speech combined with no vocal communication, and loss of useful speech. Now, in addition to the already existing options, we added 2 additional options to be more sensitive. For example, we added occasional speech disturbance not detectable to others. but noticed by yourself. So that indicates, oh, I feel there's a little bit of change, but other people who doesn't talk to me all the time may not notice, but I notice that. And then alteration in habits to improve speech. For example, avoiding specific sounds or avoiding specific words. So those are the efforts to kind of compensate for the change of your speech. Now, with this adding options, we were able to detect the change more sensitively. And in the PLS natural history study cohort, we tested whether it really works or not in the PLS population. The next scale is a little bit similar, but not the same. It's called the Rhodes Rash Overall ALS Disability Scale. And this is patient-reported outcome measure developed for ALS, but is also applicable for PLS, as I can show you later in the data. The scale contains 28 items, 28 questions. It's a little easier to answer these questions because you only choose from 0, 1, and 2. If you can do the function asked, normally it's 2. If you have some difficulties, it's 1. And if you can't do it at all, it's 0. So there are more questions, but each question is a little bit easier to answer. And the Rhodes total score goes from 0 to 56, higher score, higher function. And this scale is also advocated for better linearity, meaning that the score declines linearly and then the space between those scores are similar to each other and also has high test-retest reliability. So this is typically done with ALS-FRS-R as an adjunct outcome. So what it looks like is kind of like this. I'm just showing you the first 13 questions, but each question you can see is relevant and also easy. Not yes or no. Can you nod yes or no? If you can do it normally without difficulty, you answer 2. If it's abnormal, you have some difficulty, but you can do it, it's 1. Unable to perform, it's 0. So from the patient or participant's point of view, I think this Rhodes scale is quite easy to do, and you can easily self-report without any interviewer. The first two scales I showed you, PLS-FRS and Rhodes, they are patient-reported, participant-reported outcomes. Now, the PAN upper motor neuron score is a clinician-reported outcome, meaning you need some kind of examination for this scale. But it's a very helpful scale to estimate how much of the upper motor neuron degeneration can be detected by neuroexamination. So for example, some of the signs that you have upper motor neuron degeneration are stiff muscles. When we test your muscle tone, your muscle stiff. And then when we check the reflexes, like tapping your biceps tendon in your arm, tapping your knee jerk in your knees, if you are responding very quickly or briskly, we rate them higher numbers, like 3. And when we see something like ankle clonus, when we tap the ankle tendon and your foot goes boing back and forth, that's called clonus. So those kind of findings gives us this score, and we can add those together and see how much of upper motor neuron findings we see in the neurological examination. The next outcome, timed up and go test, is a functional and performance outcome. So this is something that can be quite objective because it's hard to say something different when your actual function says the other. This is a test where we ask you to stand up and walk a certain amount, come back and sit down. And we measure the time, how long it takes to complete the task. So you can see how you need different functions to complete this. You need to be able to stand up, you need to be able to walk, and then come back and sit down. Those are the tasks that you need to complete. And then if you are normal, you will take less time to complete the task. Finger and foot tapping are quite straightforward, yet still useful tests to measure your stiffness or the muscle dysfunction. Basically, we'll ask you to tap your fingers as many times as you can within the 10-second duration, and we'll be counting how much tapping you can do. Foot tapping is the same thing. You tap your foot on the floor and we count how many tapping you can do in 10 seconds. So this is a performance outcome similar to the up and go test. And then lastly, we want to see how we can measure your quality of life. Quality of life can be affected by different things. Of course, your function would affect a big part in the quality of life, but there might be other things like depression or medications or financial aspects. All these things can affect your quality of life, and we wanted to make sure we measure in some degree how the disease affects your quality of life. And we use two scales, ALS-SQ5, AQ5, and NeuroQOL scales. Now, lastly, the slow vital capacity is measurement of your vital capacity, how much respiratory muscles are affected, and it's measured as a percentage of the normal expected value for your vital capacity. And you might have an experience with blowing into the tube as much as you can, like, and then the respiratory therapist would tell you you can blow in, blow in, blow in, blow in, and then you're gonna finish blowing it, and that tells us how much vital capacity you have. It's low vital capacity compared to FVC, forced vital capacity. Slow vital capacity can be a little bit more accurate when you have a problem with bulbar function, so you don't have to tightly seal your lips around the tube. All right, so I have shown you different sets of outcome measures that we used in this cohort. I know that's a lot of information, so if you have any questions, feel free to ask me a couple before I proceed.
Well, here's your chance, you guys. Anybody got any questions about what he has covered so far? Well, there was some comments about the bull bar, and they would like to have some more comments and discussion about that. So you may even build that in, or you can.
Yeah, feel free to type in if you have trouble, asking questions right now, and I'll be happy to take a look at them and answer them later on. Now I'll have a little bit more juice now with the results from the study. So I showed you that we enrolled the 76 participants in different groups. You see in each column represents different groups of participants, all the PLS, probable PLS, and definite PLS. And we compared demographics, their disease outcome measures at baseline, neurofilament light level at baseline, and how many later received ALS diagnosis after 1 year, and how many died during our follow-up. The age of our participants was pretty similar across three groups at around 60, and that fits with our previous understanding. The average onset of age in PLS is around 60. Some are in the 50s, some are in the 40s, some are in the 70s or 80s, but the middle age is around 60. PLS affects male and female pretty similarly. So you can see that the proportion of male in all groups were around 50%. And the disease duration is obviously longer in definite PLS because that's how we group them. So all the PLS had less than 2 years of duration. Probable PLS had somewhere 3 to 4 years. And then definite PLS participants had way longer duration, near 8, 9 years at the time of the cohort enrollment. Interestingly, the baseline functional scores, both in PLS-FRS and ROSE, were much higher in the OLE groups. So OLE groups had better function at the time of enrollment. Also, interestingly, the neurofilament light, which is a marker of neuronal injury, how fast your neurons are degrading, was much higher in the OLE PLS group. They had higher neurofilament level. When we looked at how many participants in this cohort developed or progressed to ALS, 3 out of 26 in probable PLS and 2 out of 44 in definite PLS later received ALS diagnosis by the site PI's judgment and also EMG test. And there was no significant difference. These are all small numbers, so very small portion got later diagnosed with ALS. Notably, none of the early PLS participants were diagnosed with ALS, and all of the PLS participants survived the first year except one, who I believe died, not related to PLS, but related with a fall, so indirectly related. I'm showing you how the function declined over time in these groups, and I'm showing you three different colors. The red is the early group, those who had the shortest disease duration. Blue is the probable group in the middle, and then the green is the definite group who had the longest disease duration. And as I mentioned before, people with the early PLS had much higher function at baseline enrollment. However, you can also see that the rate of decline, how the function declined over the 12 months period, is much steeper in the early PLS group, and they later had a similar function with other groups at 12-month follow-up time. The slope was 0.33 points decline per month in PLS-FRS, and the slope was 0.5 points decrease per month in ROSE. But essentially, these two scales are showing you the same story, that the decline over time is gradual, it's pretty linear, and it was faster in the early group. We looked at other outcome measures and tried to interpret those results. I mentioned that you can do functional outcomes, for example, finger tapping or foot tapping. Pataka is basically repeating pataka for 10 seconds, and we count how many times you can do patakas. And interestingly, only the early group showed decline in pataka, finger tapping, or foot tapping. The middle one, the probable, and the slowest one, the definite PLS groups, they were pretty steady with those counts over 1 year period, meaning that they didn't really decline much in that time frame. Only the early PLS group declined with the counting. Also, with the slow vital capacity, when we measured how much of vital capacity you had in the first 12 months, we did not appreciate obvious decline, maybe a little bit in the early group, but pretty steady in the middle, the probable, and the late, the definite PLS groups. The pan upper motor neuron score, how much of signs we find on the neuro exam that represents upper motor neuron dysfunction, actually increased in the early disease group. So in the early PLS group, neurologists were finding more and more upper motor neuron signs, while in the definite and probable group, they already started with high level, meaning they already developed a lot of stiffness or brisk reflexes at baseline, and it didn't change much over time. Now, lastly, timed up and go test, how long it takes for you to stand up, walk a distance, and come back and sit down. It actually declined in the definite and probable group, more so in the definite group, meaning that people learned and walked better in 6 month and 12 months duration, while it was similar in the probable and early groups. So what we learned in other outcome measures is that most or all of these outcome measures probably not sensitive enough, especially in the probable or definite PLS group, because it didn't reflect much of change over the 12 months period. Now, after that, we looked at how these different outcomes are interconnected with each other. How are they measuring similar things or different things? And the number you see, if the number is higher, that means the two outcome measures are measuring the similar domain, similar items. And what was very interesting, the PLS-FRS, the total score, was reflecting a lot of these outcome measures. For example, PLS-FRS total score was highly correlated with the ROSE total score. So I mentioned that they might be measuring a very similar functions. It also correlates with the functional outcomes such as finger tapping, foot tapping, as they are significantly correlated. So PLS-FRS, although we ask you about your functions, it actually reflects how you're actually functioning with your fingers, your foot. It also reflects your quality of life as it correlated with the QOL scale. And it reflects to some degree timed up and go test, how you're walking, and upper motor neuron score as well. So this gives us a good idea, PLS-FRS, as we developed, particularly targeting the PLS population, it does seem to reflect all the other outcome measures that we used in this cohort. Interestingly, the slow vital capacity, the breathing capacity, did not really correlate with most of the other outcomes, meaning that the vital capacity might be an independent domain. It only has a small correlation with bulbar score, meaning that the bulbar function in PLS might be affecting your breathing function. One of the important outcome of this cohort is that we were able to calculate how much people we will need to enroll in the trial if we want to show certain effect of the medication. For example, if we use PLS-FRS as the main outcome, and we observe you for 12 months during the treatment, and the medication that we are using in the trial may have 50% of effect size, meaning that we can reduce your progression rate to half, then we would need 50 people in each arm to complete the trial and show the benefit. Now, 50% per arm, usually we have two arms, the treatment arm and the placebo arm, would result in 100 people in the trial, which is challenging given the rarity of the disease, but doable if we can do this as an international joint effort. So that gives us hope. If we use this PLS-FRS scale, if we have a similar population that we enrolled in the PLS natural history study, if we have a medication that might have a strong effect, we will be able to do PLS clinical trial. Now, if we only enroll definite PLS patients, those who progressed and have more than 4 years of disease at the time of enrollment, because I showed you they progress much slower, we will need a lot bigger cohort to show the same benefit. For example, even when the medication can reduce 50% of the progression, so half of your progression rate, we would still need 118 people per arm, meaning that we need over 230 people in the study to show the benefit, which would be far, far more challenging than just 100 participants. Another interesting observation we made in this cohort is we found that neurofilament light, which is a marker of neuronal injury commonly used in ALS population, is also a good marker in PLS. For example, we measured baseline blood NFL levels, and I assessed, examined, and see whether the concentration tells us about the future progression in the next year. And what I found is that if the neurofilament level is higher, that's on the x-axis, the PLS-FRS slope, meaning the functional decline, the slope of functional decline, is also steeper, meaning that you lose more functions with time. So you're progressing faster. So this can be a good marker in the clinical trial or even in the clinical setting if you are following a neurologist or ALS provider. You might ask to check your neurofilament level. If the neurofilament level is low, meaning within the normal limits, that might indicate that the disease progression is likely going to be slower. If the neurofilament level is higher over the limit and maybe twice or 3 times higher than the limit, that might indicate the progression might be a little fast. Now, it also predicted how participants would stay in PLS or later develop ALS or receive ALS diagnosis. For example, if the blood neurofilament level was over 90 picogram per ml at baseline, this predicted with very good specificity, meaning that most likely ALS diagnosis at 1 year. So that kind of gives us an idea. even when you don't have obvious signs of lower motor neuron degeneration and your provider is considering PLS diagnosis. If your neurofilament level is very high, that gives you an idea maybe this would soon or later progress to ALS.
So
We
I did have one question on the
Sure.
scale for the NFL level. So I had a lumbar puncture. And the scale that I received back was 0 to 3.78. So from what I understand, there's two different scales of NFL when you take that test. Is that correct?
That's a very good question, and there are many different concentrations ranges because each labs use different methods. So these NFL concentrations were measured with research device, and it doesn't have the same range with the commercially available testing, for example, through LabCorp or Mayo labs. So you cannot use this number directly to your numbers.
Yeah,
Okay.
so mine was through LabCorp. That's who I had that test from. And I was above the range, but it's hard to say how that translates to these higher numbers that you're kind of pointing out here.
Right. Well, I can't directly translate these numbers to LabCorp numbers, but from my own experience, don't quote me on this, I think these numbers that I have here is about 6 times of the LabCorp number.
Okay.
So meaning that if I translate 90 picogram to the LabCorp number, it will be somewhere around 15, 1.5. Although those numbers are not precise.
Okay. And then do you really see benefit of frequent, getting your NFL number, 6, 12 every 6, 12 months? I understand you're setting a baseline, but ultimately, if you have a diagnosis, is there really any benefit in repeating that test?
I would say it's a case by case scenario. I wouldn't recommend checking NFL for everyone for every visit. At this time, we are also learning still about NFL. We don't have years of experience. It's been used in the clinical setting only about a couple years. I typically check at least 2, 3 times to see what the trend is. The usual trend, NFL levels would stay steady in most of the patients. So once you confirmed the level steady, I don't think you need to check it every time. Now, when you introduce a new therapies or medications, sometimes I'm curious to check the NFL to see if there's any change in NFL after using those treatments. For example, the Qalsody medicine for SOD1 ALS has been known to reduce the NFL level by about 50%. So in that case, I might check and see if the NFL level is actually going down. We don't know if the ALS medicines like Riluzole or Radicava really reduce NFL levels. So we might check it and see if there's any changes. So far, I'm not seeing much of changes with those other medications.
Okay, thank you.
Of course. Now, I thought the equipment use might be kind of interesting. A lot of our, PLS population use these kind of equipments to help their mobility, to help their communication and breathing. You can see that from baseline to follow-up, a lot of people have moved up. For example, from cane to walker, more people are using the walker. From walker to wheelchair, the wheelchair or power wheelchair use has been increased, and that's kind of expected. One thing that was kind of interesting and caught my attention is the use of breathing machines. About 23% and 31% used a breathing machine at baseline and follow-up. But interestingly enough, about half of them were CPAP. CPAP is a machine that people typically use for obstructive sleep apnea, as it provides constant high pressure, compared to BiPAP, which is a bilevel positive airway pressure, and is typically used in people with motor neuron disease like ALS and PLS. So that I think needs a further exploration, whether the CPAP is used because of obstructive sleep apnea or for this PLS condition. So kind of summarizing what I showed you in the past slides, we have shown that PLS-FRS is really a good outcome as it shows the decline as it requires less number of participants for the clinical trial. It reflects most or all of the domains that's relevant to this population. And there's also a good alternative or adjunctive measure, which is ROADS. I think the combination of PLS-FRS and ROADS in the future trial will be very promising. We also demonstrated that it's critical to enroll only PLS participants because they tend to progress a little faster. And that means the required sample size will be smaller. So when your slope is steeper, it's easier to show that the medicine is changing the slope. Now, alternatively, if we use a medicine that has more symptomatic benefit, we're not targeting to change the course of disease. We're targeting to, for example, improve your function, improve your walking, improve your talking. Then we might benefit from enrolling more stable people, like definite PLS group, because the time doesn't affect the disease in terms of function very well, so that the medicine might show its benefit in function improvement a little bit more easily. Also show that blood NFL neurofilament level might serve as a good marker for predicting the disease trajectory. We can use it to, for example, at baseline, put people in different groups, high NFL, low NFL. Or it can also be used to predict whether this participant who's currently diagnosed with PLS might later develop or convert to ALS. With this foundation of PLS natural history study cohort, now all the participants have now completed, except those who lost to follow-up. I think 82% completion is pretty good. We already have data and blood that's collected in this cohort, so I am analyzing this blood for metabolomics and lipidomics as a biomarker that might even be better than the neurofilament. And with that, we are extending this PLS natural history study cohort for additional 5 years. The reason is we observed these initial differences in the rate of progression. Now, the curiosity is that are those only PLS group continue to progress at that rate, or would that gonna be slowed down as the disease more progresses? In other words, is the only PLS group inherently just fast progressing group, or the PLS disease typically progress faster in the beginning and later slow down? We also want to see how the long-term survival outcomes would show. Instead of just a couple years, we want to follow longer. We want to see how many people would later develop ALS, and that also requires longer observation. And this extension study would be performed in the online platform called NeuroPro, which is a self-report, and I think it's more suitable for longer follow-up. We're going to have participants receive an email, and whenever they receive an email, go to this website, and they can report their PLS-FRS, ROADS, whether their diagnosis changed, what kind of equipments they're using now, what kind of medications they're taking now. It's not going to take too much time, but will be very helpful to track this cohort of people for a longer period of time. So if you have completed the PLS natural history study, first of all, thank you so much. We will be reaching out to you and asking for your participation in the extension study. If you don't hear from us, feel free to reach out, and we'll be happy to have you get re-enrolled to this extension study. And so with that, I'd like to thank our study participants. Although this is an observational study, it requires a lot of efforts from many of our participants with their dysfunction, with their difficulties. Constantly, I see a lot of efforts made from the participants to do this research. I'd like to thank NCRI for their help in NeuroPro and the database system. I'd like to thank our sponsors, especially the Spastic Paraplegia Foundation, for supporting this important study. I have my study coordinators who's helping with this project. Grace was our previous coordinator. She's now in medical school, and Selma is our current coordinator who's going to be interacting with our participants. And we have published the presented data in the Annals of Neurology. If you're interested to read more, you can access the article. If you can't access it, feel free to email me. I'll be happy to send it out to you. Thank you so much, and I'll take your questions.
Thank you so much, Dr. Lee. I know I always have questions, but I'm going to reserve some of those to let some other folks ask questions. But if you will be so kind as to provide us access to that study, we want to make sure that we put that on our website and then alert folks so that they can actually read it, download it, see whatever they need to see. So if you don't mind sending that to us, then we'll get that on. We'll get that
I'll
on.
send it to you.
Yeah, that is a
Of
very
course.
wonderful presentation. I really appreciate that. There is a question that some folks added into the box, the chat box over here. If you don't mind picking up one, there was one that talks about the neurofilament level, projected severity of the disease, or the rate of progression. You did mention that.
Yes. So, in addition to what I already answered, is there an additional question? Oh, here. Did you find that neurofilament level projected severity of the disease or rate of progression?
Yes.
Yes. So severity of the disease, not necessarily, because if you can imagine severity of the disease at baseline, meaning your function, that's a remaining function. It's a function of how fast you're progressing, but also how long you had the disease. But it definitely predicted the rate of progression when you had higher neurofilament level. The functional decline in the coming months were much faster. So I think that directly translates because neurofilament reflects how fast your motor neurons are degenerating. So you can expect that your function would deteriorate faster with the higher level. Mhm.
Yeah, thank you very much, Dr. Lay. That I hope that answered everybody's question. And as you know from what he said earlier, how many of you, just by a show of hands, how many of you have actually had a neurofilament test? Do you know? Okay, see one, and then the guy that called in. So this is a subject that we might need to have some more conversations about.
Yeah, and there was a question about the CSF, the lumbar puncture,
Yeah.
neurofilament level.
Mhm.
So the neurofilament that I tested was from the blood, and the level of neurofilament is very different between the blood and CSF. So you need to be clear which sample you measured neurofilament from. The ranges would be very different for blood and CSF. Commonly in the clinic, because the lumbar puncture is difficult to do, your doctor would send your blood for a neurofilament test.
That is so good. That is so important, and I appreciate that distinction. Thank you
Mhm.
so much for noting that.
Yeah. There's a question about, are you enrolling new patients for the study? Uh, Unfortunately, we are currently enrolling people who completed the original PLS natural history study to this extension study. And that's because we need the first 2 years of data to make the extension meaningful. So we're not enrolling new patients. But if we do a new study, that's, brand new study, then we'll make sure to let you know.
Well, and that's one of the things, Dr. Lee, that you'd said earlier is having some more patients to get involved in studies. And that's the thing, you guys, we have got to get ourselves clinical ready. So, you've been a part of this conversation because you are a member of the foundation, right? But what we've got to do is find other people that that have PLS so that we can alert them to the fact that we may need a population that could be within driving distance of Dr. Lee or close proximity to some of the other doctors that we're working with. So, it's so important that we're able to find you and help you find the information when the doctor is ready to use your information in their clinical study. So that is so important for us to do that as we journey on this. I mean, there's many people that I would like to participate, Mayo Clinic, biomarker study. Everybody's information would be very useful, but it's a matter of collecting which doctors are we going to fund in order to continue on with a study or create a new study, right? So
That's
that's
right.
what we're constantly working at, is to try to bring all of those together and find that similar patient that's in close proximity to where Dr. Lee is. And that's what Dr. Mitsumoto did with that original study. And we're able now to continue on that in this second phase. So we're not finished by any means, right? We've got to find more that are going to study various functions of what's
Yeah.
happening in all of these types of endpoints. We've got to create those endpoints. There's a
We're just starting.
Yeah, I know, right? It's just there's so much. It's
Yeah,
absolutely
I can tell you that I just received the first batch of data from metabolomics lipidomics analysis, and it's very exciting. It's very intriguing already.
okay. Tell
I
us more. Tell us more.
I can't wait to complete the analysis and report later this year.
That is fantastic. I will look forward to that report.
Yeah. There's some
Um,
questions about medications here, it looks like.
yeah, you had
Uh,
mentioned a couple of those about reducing the NFL levels.
yeah, so I don't know too much about nalbiximols. I'm sorry. Hank said, have you looked into the command study? I'm not really sure what that means. What is the command study?
He'll write that in the
Yeah,
chat.
and Tim has raised his hand. Yes.
Yeah, so
Go ahead.
that was my question on the nabiximols. It's a cannabis-based CBD treatment that's available in Europe, but is not allowed in the US, specifically for spasticity. If there's any thoughts or knowledge on with the reclassification of cannabis in the US, any benefits or other options?
I know it's of interest of many of my patients too, using cannabis or a cannabis product. So far, there's not a lot of data on it. I can't really say it's been tested or experimented in PLS population or in general motor neuron disease population. There might be some anecdotal experiences, but nothing systematic evaluation. So yeah, I think that's one thing that I'm interested, but we lack data to say one way or the other.
Yeah, there was a paper published, and I don't have that, I apologize, right in front of me, but there was a paper published on just a PLS overview that listed that as a potential treatment. Unfortunately, it is used in Europe. It's approved by multiple countries and it has shown benefits, but apparently is not available in the US because of the categorization of cannabis.
And it's been approved or used in which patient population in Europe?
Yeah, for PLS patients. It was in a PLS study. It's in a written study. I can send that to you if you'd
Yeah, yeah,
like.
no, send me. I'm not aware of
Yeah, please
specific.
send that to
Yeah.
us as well, Tim. We appreciate that. And we'll put some of that information on our website so that everybody can access that. And Hank put over in the chat that it was the Commend program that is going on at the University of San Francisco, Wills Institute for Neurosciences. And they're looking at 120 participants in 30 study centers across the US. So,
Yeah, I opened the website. It's targeting muscle cramps.
mhm.
I see.
Yeah, I think it would be very interesting, really, Dr. Lee, if there, if some of the ALS trials and patients are able to use some of these medications to stop some of the symptoms or slow down some of the symptoms, I think that would be so beneficial for our population to maybe be able to have access to those. And I wonder, and I question Dr. Lee that, one of the very first screens that you had shown in your presentation, it talked about the survival over time compared to the ALS deaths, that were very quick in that. I wonder if there is any thought or consideration about, the quality of life in those early stages of finding out that you've got PLS, or that, whether you even know what it is. And I think that's really the hardest part is a lot of people are experiencing these symptoms, but they don't know what it is. They can't get their doctor to help them understand what it is. They don't know. And so, we're losing that ability, but we know that there's something wrong.
I
And
know,
that's what we've got to get our patients. In some ways we all want to be tough and we want to walk into our doctor's office and we want to say, "Oh yeah, yeah, we could do all these things. We could do all these things." But we've got to be honest with ourselves and say, "But I am having problems with these things." And that way
right?
they can get rated on those scales so that you are able to get that diagnosis and to get that treatment or, that information available early. Tim, you got another comment or question?
Yeah, Dr. Lee, can you just make sure your email address, if you could provide that so I can forward that study to you?
I'll put it in the chat box.
Thank you.
Yes, Lewis, he asked about speech medications. Are there any medications in that?
Well, not that I'm aware of. However, Nuedexta medicine is commonly used for pseudobulbar affect. And if you have pseudobulbar affect, Nuedexta might be a good medicine to use. There are some studies showing Nuedexta might be a little helpful for your bulbar dysfunction, like speech and swallowing. Although the evidence is not very strong, I think some people try to use Nuedexta for both emotional control and bulbar dysfunction.
There was a question here about a high dose of B12's effectiveness. Do you have an opinion about that, sir?
High dose of B12 injections we recommend for ALS patients. Some of you might know B12 50 milligram twice a week dosage was tested in clinical trial in Japan, and they presented and published those results that B12 injected group compared to placebo had much slower functional decline and longer survival, and the benefit seems quite strong. So in the ALS population, we do recommend B12 injections. Now, the PLS population was not necessarily included in the trial, to my knowledge,
Right.
but if you want to use it, I think why not? It's a supplement. It's very safe. There's not a lot of downside. It's a little expensive. It's not insurance covered. But if you're willing to take it, ask your provider to send prescription to compounding pharmacy. I think it's worth a try.
Hey, can you send me that study that you said was published in, did you say Japan?
Oh, the B12 study?
Yes, sir.
Oh, yeah, I can
Yeah, I
send
would
you
love
it.
to have that on our website. That would be fantastic.
Hmm.
What about Keppra? Do you have an information about how that might work?
Keppra is an anti-seizure medication, anti-epileptic medication. Now, a couple of my patients are actually taking Keppra, and they're taking it for their startle reflex, actually. They get startled very easily, and after starting Keppra, some reported that it got better. I don't know if Keppra helps PLS in other ways, though. Is that affecting the disease progression? Is that affecting spasticity? I'm not so certain about that.
It's so funny, Dr. Lee, because I have had in the last couple of different SPF talks, we've had this conversation about the startle factor. And it
Mm-hmm.
was born at the conference in Tampa when the PLS folks got together and ordered pizza one afternoon, evening. And Dr. Mitsumoto came over and sat around the table with everybody. Isn't that right, Patrice? And they were then able to tell Dr. Mitsumoto that that is a thing. And we thought that was just amazing that that was something that everybody, it resonated with them. So yeah, we're like, it's just amazing to me how that we
It
can all
is
find.
really a thing.
Yeah.
And Grace worked with me and Dr. Mitsumoto. We published that startle reflex is very common in PLS and surprisingly not so common in ALS. So it's something that's more distinct in PLS population. We are still wondering what's happening there. What's the underlying mechanism there?
Tim, you got another comment or a question? Go ahead, sir.
Yes, I actually tried Keppra, and I personally did not see any benefits. Another patient of the doctor that was treating me tried Keppra as well, and they did see some benefits. So certainly a little hit and miss, but I just didn't see anything from it.
Well, and that's like what we were talking about when we first got on. Everybody is in a different place, is in a different spot. in the walk and the journey of the disease, right? And so what might work for someone might not work for somebody else. So what we've got to do is figure out what is available and can it help some of our population in any way relieve symptoms and help us live a better quality of life. And that's what we're all trying to do every day. Dr. Lee, I know we've gone over and I apologize for that, sir, but you
That's
have
all
been
right.
so inspirational to us in providing the information that you have and the journey that you're on to help further along Dr. Mitsumoto and the study and all the folks that are working with you. I really appreciate your helping us today and being a part of this conversation. And we want to invite you back.
Yeah, of
Everybody
course.
agree? Everybody
I'm
agree? We
honored.
want to have you
Oh,
back.
I'm always happy to be here, and I love to hear more of your thoughts because we as a clinician researcher, the feedback from our patients, from our population, really moves us forward. Otherwise, our idea would be, gone. So.
Well,